This conference will now be recorded.
As all of you are requested, I am trying to take clinics in theory class. Okay?
Yes, ma'am.
Okay. Then is there roll number 1 is there present or absent? Roll number 1. Roll number 1 is there. Roll number 2. Roll number 2. Roll number 2. Three, 4.
Yes, ma'am.
So, can you read this slide?
Yes, ma'am. A 2 year male child brought by his grandmother with complaints of fever since 5 days, cough since 5 days, and breathlessness since 2 days.
Okay. So, what is the chief complaint here?
Ma'am, fever, cough, and breathlessness.
So with these chief complaints, what are the possibilities? Whenever any case given to you, first of all, with the chief complaints, you have to think about the possible differential diagnosis. With fever, cough, breathlessness, what will be your first differential diagnosis?
Ma'am, any respiratory tract infection?
Okay. So will you know whether it's upper respiratory or lower respiratory tract infection?
Ma'am, we have to ask for the type of cough, like whether it's productive or not.
That means in which condition productive cough will be there, in which condition non-productive cough will be there. That means I am asking difference between upper respiratory and lower respiratory in the history. Examination, before going to the examination in the history.
Ma'am, in case of like pneumonia or tuberculosis will have productive cough, and like upper respiratory tract infection generally will have dry cough.
Are you sure? That means pharyngitis and tonsillitis, dry cough will be there. There won't be any production of cough, expectoration.
Ma'am, mostly it will be dry cough.
No, we can't say that because most of the even upper respiratory running nose, rhinitis, common cold, pharyngitis, tonsillitis, we have sputum, expectoration. But depending upon the age of the child, if the age of the child is less than 5 or 6 years, usually they will swallow. And you also sometimes some females also they will swallow. But it's not that indicates it's a dry cough. So we have to wet cough or dry cough. But if we are depending upon wet cough or dry cough, we can't differentiate that upper respiratory or lower respiratory. In both conditions, there may be dry cough. In both conditions, there may be wet cough. For example, in lower respiratory tract inflammation like bronchial asthma, it's a lower respiratory tract problem. Still, the person may have dry cough. Okay, in upper respiratory infections like pharyngitis, tonsillitis, sinusitis, they will have wet cough with postnasal drip also. So that's not a valid point. So any other things, we have to differentiate upper respiratory and lower respiratory tract. Roll number 5. Roll number 5.
Yes, ma'am.
So how will you differentiate history-wise upper respiratory tract infection or lower respiratory tract infection?
Ma'am, upper respiratory tract infection, the patient will have a problem while swallowing also, like throat pain and everything will be there. In lower
Okay.
respiratory tract infection, there will also be wheeze and wheeze and like productive cough will also be there.
Okay. Anything? Anything else? So if there is a painful deglutition, difficulty in swallowing, maybe possibility more likely upper respiratory. Okay. Anything else? Any other history-wise? Any other points?
Ma'am, and if it's like ma'am, if it's common cold, like mostly it will be upper respiratory tract. Associated
Roll number
complaints.
6. Okay, roll number 6 is there. Roll number 6. I'm noting the numbers. If anybody is not answering, at least say present, or if you know the answer, you can answer. Otherwise, we can proceed to other roll number. So roll number 6 is absent. 7. Roll number 7.
Ma'am,
Magna. So what are
yes,
other
ma'am.
points? What are the other points to differentiate between upper respiratory tract and lower respiratory tract?
Ma'am, breathlessness.
Breathlessness. Okay, breathlessness. More in
Hello,
favorable
ma'am.
to upper respiratory and lower respiratory.
Hello, lower respiratory, ma'am.
Anything else?
I'm 6. Present.
Roll number 6. Who is this? Name. I
Vishesh.
want.
Ma'am,
Vishesh. Okay.
Vishesh.
Okay. 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 Vishesh. Anybody from the class? Open to class. Anybody can answer. How will you differentiate between lower respiratory and upper respiratory tract infection? It's a common asked question in the orals. Whenever you get complaints like fever, cough, and breathlessness or fast breathing, so you have to differentiate with other histories. What other complaints you will ask? Leading question. Sometimes parents may forget and to tell something. So you have to ask all those things. Pawan,
Ma'am,
Pawan,
Ma'am, productive
ma'am,
how
cough
to
or
differentiate
non-productive cough?
clinically upper respiratory and lower respiratory?
upper respiratory tract,
Productive cough and
nasal
non-productive
congestion,
cough.
sore throat, headache.
Headache. Okay, headache will be there. Any fever, whatever may be fever, high grade fever can cause headache.
Tachypnea,
We
ma'am.
can't.
Tachypnea.
Tachypnea. Okay, tachypnea is more favorable towards lower respiratory tract
Lower
infection.
respiratory.
Lower
Okay.
respiratory tract,
Anything
dyspnea,
else?
productive cough, fine crickles on
Productive
her.
cough is not a lower respiratory. That's what I discussed till now. Productive cough can be there in pharyngitis, tonsillitis. I think all of you might have at least one episode, more than one episode of pharyngitis. Never had sputum? No. So don't say that productive cough is always equivalent to lower respiratory. Productive cough can be there in lower respiratory, upper respiratory. Examples like simple pharyngitis, tonsillitis, common cold, everywhere. Upper respiratory also will be sputum production. We can't say that it's a differential curve. Valid points are if there is a throat pain, sore throat, or discontinued swallowing, painful swallowing, more favorable towards upper respiratory tract. Okay. Tachypnea valid towards low respiratory tract infections. Anything else like retractions? Why people are not talking about the retractions? Subcostal and intercostal retractions favorable towards lower respiratory and upper
Lower
respiratory.
respiratory tract, lower
Lower
respiratory
respiratory tract
tract.
infection. Because parents may tell mother and grandmother in Telugu they will call as pakalagarestunaru, dokalagarestunaru. That is equivalent to retractions. So lower chest retractions or subcostal retractions. Hurried breathing or fast breathing, tachypnea. In their own words, they will tell us fast breathing or hurried breathing. So that is equivalent to tachypnea. So tachypnea and retractions towards lower respiratory tract infections. Okay, sometimes associated with like feeding difficulties, unable to take feed, decreased feed intake, toxic look, ill look, sick look, or cyanosis. Severe pneumonia, there will be cyanosis. There is cyanosis, and also intensity of the symptoms. If the cough is so severe and interfering with the food intake, usually maybe lower respiratory, but it can be observed in case of upper respiratory tract infection like 100 days cough. What is that condition? 100 days cough. Divya is there. 100 days cough. What is the other name
Yes,
for
ma'am.
that? What is the other name? Upper respiratory infection presenting with
Whooping cough.
Pertussis.
pertussis, whooping cough. Pertussis otherwise called as 100 days cough. When there's upper respiratory tract infection, it causes severe symptoms and can lead to so many systemic complications also. So all of you has to know how to differentiate in the history upper respiratory and lower respiratory tract infections. Okay. Next, roll number 9. Who is roll number 9?
Ma'am.
Divya.
Yes, ma'am.
Read the present history. History of presenting illness.
Present illness started 5 days ago as nasal discharge and later developed cough and fever. Fever is high grade continuous associated with chills subsiding with antibiotics. Cough is productive. Cough is more during night times. Cough is productive. Sputum is swallowed by the child.
Okay. So what is your impression? Still, it's their cough description. Oh, okay. Tell.
Each episode of cough is followed by vomiting. Vomitus is mucoid, yellowish in color, no blood, no food particles. History of breathlessness in the form of rapid breathing observed by his grandmother 2 days back, no diurnal and positional variation.
So what is your impression after taking the history of presenting illness to this level? So what is your impression? There is tachypnea is there, contractions are there. And
It's lower
cough,
respiratory tract infection.
contractions are there, and my mother noticed anything, not grandmother. So sputum child is following, but each episode of cough is followed by vomiting, means that is severe cough. So rapid tachypnea is more
Yes,
targeted to
ma'am.
lower respiratory or upper respiratory. Fast breathing, rapid
Lower
breathing.
respiratory, ma'am.
Why they mentioned about diurnal variation and
Lower
positional variation? In which condition child may have diurnal variation of breathlessness? Diurnal more in night time or more in daytime, like that.
in cardiac causes, ma'am.
Like this specific, don't say any cardiac. Cardiac means so many are there, congenital, acquired, all those. Don't use the word any. This specific.
Right heart failure, ma'am.
In the form of usually paroxysmal nocturnal dyspnea, PND. PND means maybe postnatal with paroxysmal nocturnal dyspnea.
Right heart
So,
failure.
paroxysmal nocturnal dyspnea, more cough whenever child go to sleep, especially in the night time. So that may be the manifestation, and positional variation to exclude orthopnea. Okay. So no positional variation means to exclude PND and orthopnea. Okay. Next, roll number 10. Upset 11.
Ma'am, present. Ma'am, 10%, ma'am.
Okay, Kalyan. Read this slide.
Child is not accepting feeds well. History of palpitation present as perceived by grandmother. Family belongs to lower socioeconomic class. Child is born to a non-consanguineous couple at term with uneventful antenatal period. Baby is delivered by NVD at term. Normal vaginal delivery at term. Cried immediate and postnatal period is uneventful.
Okay. At this history, feeding difficulty is the child not accepting feeds well. So there is some problem while taking feeds, or maybe is very sick, so is not taking feeds. So anything else, grandmother given important to you in this slide? History, positive important history. Kalyan, any important history is there in this slide?
Palpitation.
So grandmother perceived palpitations. So here child won't tell that he is having palpitation because age of the child is 2 years. So grandmother perceived palpitations means whenever grandmother holds the child against the shoulder, like when holding the child against the shoulder, she will perceive the increased precardial activity that is equivalent to palpitations. Okay, all of you got? Is it okay? Any doubts up to this
Yes,
level?
ma'am.
And question to the roll number 11. Who is roll number 11?
Present, ma'am. Present, ma'am.
Nagasai. Okay. What antenatal history will take? Here, uneventful like that we mentioned because it's a case scenario. But in case, what up to this level, what do you think the child is having? According to the primary chief components, lower respiratory tract infections, and followed by there is a history suggestive of palpitations and feeding difficulties. Maybe some underlying congenital heart disease also.
Yes, ma'am.
Okay. Here anything else important? Uneventful antenatal history here mentioned, but what antenatal history you have to ask whenever you suspect a congenital heart disease in a child?
Any infections?
Don't use the word any. Most of you are using the word any. Any means a vague word. history you will ask in the antenatal period for whenever you suspect congenital heart disease?
Torch infection.
Torch infections. So how will you ask her? You won't ask mother or grandmother, is there any history of torch infection? No? What history? In their own words.
Fever with rash.
Any history of fever with rash in the first trimester of pregnancy. Any history suggestive of at least fever with rash in the first trimester of pregnancy to exclude what is specific infection which can cause congenital heart disease to the newborn.
Toxoplasmosis.
Toxoplasma. Which congenital heart disease causes caused by toxoplasmosis?
Rubella, ma'am. Congenital rubella syndrome.
Patent of Paediatrics.
Somebody is. One is
PDM.
congenital rubella syndrome. So it causes PDA, patent ductus arteriosus, and other peripheral pulmonary stenosis, VSD, and other heart diseases. Also, most common is PDA. Peripheral pulmonary artery disease is the most common. Okay. Any other infection can cause, any viral infection to the mother can cause congenital heart disease. Open to the class. Anybody can answer.
Cytomegalovirus.
CMV, ma'am.
Be loud. Divya.
CMV, ma'am. Cytomegalovirus.
Cytomegalovirus infection. Anything else? Any other viral infection? Very common actually. It's viral infection, but it can cause mumps antenatally affects the mother. In the first trimester of pregnancy can cause endocardial fibroelastosis. Okay, these are some of the viral infections can cause congenital heart problems. So anybody can name some drugs. Not anybody. Roll number 12. Who is roll number 12?
Ma'am, present, ma'am.
Saket, can you mention some drugs? Teratogenic drugs can cause congenital heart disease.
Epilepsy can cause hypertension.
Lithium, ma'am.
Thalidomide.
Just mute. You are answering only should unmute your this one.
Thalidomide.
Okay. You are not clear.
Thalidomide.
Thalidomide. What the congenital heart problem caused by thalidomide? I not asked name some teratogenic drugs. I asked teratogenic drugs which can cause congenital heart disease. Roll number 13.
16 anomaly, ma'am.
It is making noise. So mute yourself. 14.
Yes, ma'am. Retinoic acid, ma'am.
Anomaly.
Ma'am, lithium, ma'am.
Lithium, good.
Ma'am, lithium.
Depressive illness causes what problem?
Phenytoin, ma'am.
Lithium, good. You told correctly. Lithium causes what malformation?
Epstein anomaly.
Epstein's anomaly. Okay, good. This is good for your PG entrance also. So all of you should know the infections. Infections which can cause congenital heart disease and also teratogenic drugs which can cause congenital heart disease for your orals and also for your PG entrance. If you prepare a table, it will be very for the future. Okay, you should take all those. So here they will write there is no perineal aspect here. All of you mute yourself.
Ma'am.
Okay. Chapat, can you read this slide?
Yes, ma'am.
Child developed similar complaints at the age of 6 months, admitted and treated for 20 days in GGH. Development of the child is delayed in gross motor milestones, walking without support attained at 2 years, other domains normal, immunization incomplete, grandmother could not recollect.
So what is your impression with this slide? What is your grandmother gave to you?
Ma'am, that there is delay in the motor milestones. The CNS system is affected.
Before that past history, something is there, no?
That the child had similar complaints at the age of 6 months, ma'am.
So my aunt treated for how many days? 20 days in GGH में government general hospital. So treated for 20 days. Might have some severe problem. Do you think
yes,
probably this history of presenting illness, some congenital heart problem with lower respiratory tract infection? Similar complaints means child had lower respiratory tract infection.
Yes,
that's why usually they will give antibiotics for 14 days or more. So treated for 20 days. Or might develop some congestive heart failure like features and might be treated for 20 days.
Yes, ma'am.
Okay. So that history you have to you should include in the case.
Yes,
positive history take into consideration. So for 2 years child he had similar history 6 months ago. For what child was treated for 20 days means a severe problem, not a simple upper respiratory infection. Okay. Next documented history is gross motor delay. Other milestones are normal. Okay. Immunization, because grandmother is not, mother is not available. Grandmother she is unable to recollect that. So we have to take it as partially or incomplete immunization.
Yes, ma'am.
Okay, next. Roll number 15. Who is roll number 15? Sweta, present? Okay, read this. Sweta, not audible. Okay, roll number 16. Mute yourself, Sweta. Your voice is not clear. So 16, roll number 16.
Yes, ma'am.
Girish, na?
Yes,
Okay,
ma'am.
Girish. Okay. Is it clear? You can see the slide now. You can read this one.
Yes. Anthropometric findings are weight of the baby is 8 kgs, height is 70 centimeters, occipitofrontal circumference is 40 centimeters, mid-arm circumference is 13 centimeters.
Weight for 2 years. What is the expected weight for 2 years child? Usually here child is 2 years. Here it is 8 kgs. Is it normal? Just looking at this, what is expected weight for 2 years child?
Not normal, ma'am.
What is the expected weight for 2 years? For 1 year, what is the expected weight if the child both weight is normal?
8 to 10 kgs for 1 year, ma'am.
8 okay, depending upon usually child's weight normal 3 kgs or 3.5 kgs. Usually expected weight at 1 year is 10 kgs. At 2 years is
15
years 15 kgs. 12 kgs. Otherwise, you can carry your growth charts. This is the growth chart you can see. You can carry growth charts for examination or exam. In the exam also, we can provide also. You can ask for skilled assistant. Are you able to see this growth chart?
Yes, ma'am.
So interpret. So 2 years means 24 months. 24 months here, weight, height, and where the chart is there. So you can see it's here, weight, 24 months, how much?
12 kgs.
12 kgs. So it's 8 kgs. So here, are you able to see Z scores? -1 or -2? The slide show. Now we can see, I think. So 24 months, is it below -1 standard deviation or -2 standard deviations? So here growth stats we can take because expected weight for this child should be around all cases. So both weight and height or length is affected in this child. Okay.
Yes, ma'am.
Next, roll number 17. Roll number 17. Absent 18. 19.
Ma'am,
20.
Yes,
18.
ma'am.
Is 18.
Yes, ma'am.
Shahiti. Okay, read
Yes.
this slide.
Child is not anemic, no cyanosis, no clubbing, no jaundice, no edema, and no lymphadenopathy.
Okay.
Dysmorphic features like upward slanting, palpebral fissures present bilaterally.
Slanting, upward slanting palpebral fissures are present. What do you mean that? What do you call upward slanting palpebral fissures?
What?
What is the name given to upward slanted palpebral fissures? There is a name.
Mongoloid faces.
Mongolian
Faces.
faces.
Mongoloid.
What the feature is the faces. Mongolian faces are, I mean, like hemolytic faces. But this particular feature, I'm asking what is this particular feature are always called as Mongolian slant.
Mongoloid slant, ma'am.
So what is anti-Mongoloid slant then?
Downward
Give us
slanting of
this downward slanting. Okay. So upward slanted palpebral fissure, that is Mongoloid slant present bilaterally. Next one more feature is there.
Yes, ma'am. Little finger is short and incurved.
What do you call that? If the little finger is short and incurved, what do you call it? What is the name given to that feature? I'm not given directly because you should be in position to answer. That's why. Ahiti.
Down syndrome.
What is the name given to this feature? Then tell them Down syndrome. Why little finger short and incurved here? Because of hypoplasia of the middle phalanx of the little finger. It is called as clinodactyly. Okay.
Okay, ma'am.
So clinodactyly, mongoloid slant, and other features also there. What are this much features is here wanted to tell that the child is having some genetic syndrome. So most probably Down syndrome. What are the other features of Down syndrome? General examination. Palms, anything you can see?
Absence of palmar crease.
Absence of palmar creases and single palmar crease, not absent. Single palmar crease will be there. That's why otherwise called as
Simian crease.
simian crease. Simian. Okay. So these dysmorphic features are there like mongoloid slant and clinodactyly and other features like simian crease. We have to suspect Down syndrome, genetic syndrome. So there is a clue given to you. Okay. Next. So roll number 19. Roll number 19
Yes,
is
ma'am.
there.
Yes, ma'am.
Lakshmi Priya. Read this slide.
Yes, ma'am. On previous examination,
Read.
JVP is JVP is raised. Apical impulse is in fifth intercostal space, lateral to midclavicular line, normal in character. Precordial pulsations present. Precordial bulge positive. no parasternal heave, systolic trill present in left fourth intercostal space, parasternal region, no palpable P2 on auscultation, S1, S2 normal, murmur head.
This is the murmur. What do you, by seeing this, what do you think this is a murmur? Cycle, in cardiac cycle, which it comes for which phase of cardiac cycle? What do you call this murmur? This is the murmur. You can see these interrupted lines are murmur. What is this phase? It started from S1 and present up to A2. Second song. What do you call this murmur?
Pansystolic murmur. During the systole, it is present, ma'am. Entire systole, so it is called pansystolic.
So it's called as pansystolic murmur. Okay, here it is case scenario because we are not having the case. That's why I given a case scenario. So by the time if you appear for by January or February, case comes okay. Otherwise, you have to appear with case scenarios only. Okay, for that purpose, I am taking case scenarios. So here with this slide, you can see that child is having raised JVP, apical impulse in left fifth intercostal space lateral to midclavicle line. That means is it normal for this 2 years child?
No, ma'am.
Usually it will be medial to the midclavicular line. It's lateral to midclavicular line. And usually left fourth intercostal space will be there at this age. So it's down and also out. Down out of apex. Indicates usually left ventricular hypertrophy is there. But not present overload. That's not that much.
Ma'am, your voice is not clear.
What? Deepika,
Your voice
somebody is talking. Not clear. My voice is not clear. Now
yes,
is
ma'am.
it okay?
Yes, ma'am. It's okay, ma'am.
Okay. So JVP raised and apical impulse. Here it is down and out. It was shifted down and also laterally. So there is a hypertrophy of the left ventricular hypertrophy is there. And if it is right ventricular, usually how it will be? It will be only out. It won't shift down clinically. And precordial bulge is there. So it's something since long back. It's not acute condition. So something like congenital heart problem usually have a long-standing problem. They will have precordial bulge. And systolic thrill here is palpation. You have to write like inspection. It is a case scenario. That's why I given like this. But in the examination, you have to write cardiovascular examination, inspection. Inspection. These are the findings like JVP rise, apical impulse, visible in which area, and precordial pulsation and precordial bulge. Up to this level will be the inspectory findings. And palpation, you will look for the parasternal heave and also any thrills are there or not. Here, systolic thrill is present. The left fourth intercostal space, parasternal region. Okay, no palpable sounds. So, palpable P2, usually palpable P2 is there means pulmonary hypertension is also there associated. Here it is not palpable. There is no palpable P2. Only systolic thrill is here. Whenever systolic thrill is there means that indicates murmur is above which grade? Deepika, which grade? Systolic thrill is there means what grade of murmur?
Ma'am, third grade.
Third grade. Are you sure? Beyond third grade, up to third grade, loud murmur only grade 3. Grade 4 and above only thrill will be there. Thrill means above fourth grade. 4 or above, 4 or above, up to 3. Who is roll number 21? Roll number 21?
Ma'am, it's me only, ma'am.
Okay. Deepika only. Can you grade murmurs? Systolic murmurs grading?
Yes, ma'am. Grade 1 soft. Grade 2 is a palpable murmur. Ma'am, actually, I'm not sure, ma'am.
Okay. Anybody from the class? Anybody confidently can grade the systolic murmurs? For general medicine and also pediatrics, it's important. In general medicine also, they will ask same question. CVS may be long case in general medicine or in pediatrics. Anybody? Pavan? Pavan is there?
Ma'am.
Can you grade systolic murmurs? Can you grade systolic murmurs? Anybody
Ma'am,
other than?
grade 1, very faint.
Okay, Divya. Divya, be loud and clear. All others also listen to you. Okay. Grade 1 is?
Very faint murmurs, ma'am.
Okay.
Grade 2, soft and no thrill and heard in all positions, ma'am.
Okay.
Grade 3 is moderately loud, ma'am. And grade 4 is loud and there will be a palpable thrill also, ma'am.
Okay.
And grade 5, it's very loud along with thrill, ma'am. And grade 6 is like very loud sound with the thrill heard with stethoscope, ma'am.
Are you sure? Up to grade 4 you are okay. Grade 5 and 6 you are not clear. Anybody can add better than this? Divya is okay, maximum, but it's not 100%. Anybody? Okay, then I will tell. Grade 1 is very faint moments, very difficult to hear also. Only in calm, silent room, only will be with very expected, only will be audible. So it's very rarely we can hear the grade 1 moments. Grade 2 is bit louder, but it can hear in normal room. But grade 3 is a loud murmur without thrill. Grade 3 is a loud murmur. Murmur intensity will be loud, but without thrill. Grade 4 is loud murmur with thrill. Grade 5 is loud murmur, thrill will be there, but can be here even half of the chest piece is attaching the chest. With your step, only some part is touching the chest, then also we can hear. But grade 6 is off the chest also, just near. If you put the stethoscope, bella diaphragm near to the chest, but without touching the chest wall also you are able to hear. Okay? Got it? Divya, is it okay? Is it clear?
Yes, ma'am.
Go and read again. Okay? This name is also there for this class.
Ma'am, once repeat, ma'am.
Grade 1 is very faint murmur. Only in silent room with very expected only will be able to hear. So you people may not be able to hear grade 1 murmurs, even myself also. Because it's very calm without any sound interruptions, with very expected. Only cardiologist may or may be also without will be able to hear the grade 1 murmurs. Okay? So it's very rarely we can hear the grade 1. Grade 2 is louder, but will be with normal room you can hear grade 2, but it's not that much moderate loud only. Grade 3 is loud murmurs, but without any thrill. The loud intensity will be loud, but there is no thrill, palpable thrill. So grade 4 is loud murmur with palpable thrill. This is a grade 4 murmur. Grade 5 means loud thrill will be there. Even the stethoscope piece, that diaphragm, only 50% is attached to the chest. Also you can hear, not completely also. But grade 6 is even off the chest. It's not even touching, but near to the apex area. If you put the step without touching the chest also, you will be able to hear the murmur. That is grade 6. That much loudness will be there. You can read from any standard textbook, because you don't should not mention my name to anybody. No, from which book? So you can read this from this clinical methods, Atchinson's clinical methods. Okay, or Chamberlain's clinical method, grading of murmurs. That is, should be clear, because for the both general medicine clinics and pediatrics clinics, you need to know. Now is it okay?
Yes,
okay, Divya? Read today only in the evening you can read, then we will get clarification. Because as it is sentence, I can't repeat. No, so if you read, then as it is sentence, you always tell the reference book. From which book only? Don't tell anybody's name, any professors, associates, or assistant names to anybody. Reference. We won't be standardized, human beings. So textbooks are standardized to mention the standard textbook from where you read. Okay, so here it's a systolic field present means it's a grade 4 murmur. Roll number 22. 22. 23. Roll number 23. 24. 25.
Yes, ma'am.
Absent.
Ma'am, 24, ma'am.
Sunita, 24. This
Yes,
roll number
ma'am.
24.
Yes,
Read
ma'am,
this slide.
24.
Okay.
Respiratory system, subcostal and intercostal retractions present. Bilateral diffuse crepitations present all over the chest. GIT, tender hepatomegaly present. Hepatojugular reflex present. CNS, no abnormality detected.
So what is your impression? So after listening, you are there from starting onwards, no? From the starting slide to ending slide.
Yes, ma'am.
And between you left Sunita, you are there from class starting, no? So what is your impression after reading, after knowing the chief complaint, present history, past, family, and all other histories, and the general examination and systemic examination? What could be your provisional diagnosis? One case given to you with same findings if you examine. At the end, you have to write the provisional diagnosis for long case. Okay. So what will be your provisional diagnosis?
Cor pulmonale.
Col pulmonale. What do you mean by col pulmonale?
Ma'am.
It's a pediatric case.
Okay.
Both respiratory and cardiac problem is there. That's why you call him col pulmonale. It's not like that. Okay. Anybody? Power, can you give the provisional diagnosis for this case, this child? Try once. It is wrong. If it is wrong, also nothing will happen. Just tell your provisional diagnosis. Same case, if it is given to you, what will you write the provisional diagnosis? How will you write the provisional diagnosis?
Ma'am.
Deepika.
Ma'am, because of chief complaints of cough and these respiratory system
Whenever
symptoms like
anybody asks provisional diagnosis, you have to directly tell the diagnosis. If anybody asks,
Ma'am,
summarize the case,
tricuspid
then you can tell
regurgitation with
the
pleural
positive
effusion.
history and important to negative history, then it will be okay. Now, I'm not asked about to summarize the case. I asked about the provisional diagnosis. So directly you have to tell the
Ma'am,
provisional
lower
diagnosis.
lobe pneumonia.
it's a
Why
case of
it's a
right.
Lower lobe
pneumonia?
pneumonia.
Did they mention that right side, these low drop representing areas like right intrascapular, intraaxillary areas, findings only? Bilateral diffuse crepitations are there. Bilateral, both. So all over the chest there are crepitations. That indicates bronchopneumonia. Okay. And the child is having, and the history wise difficulties, tachypnea, and retractions, palpitations, all those things. Difficult to take feeds. Actually, we have to ask Saccharase cycle was there in the past or not. That was missing in this history, but you can ask for the grandmother. Or otherwise, you can tell me that, madam, we have to ask in the past if the child used to have Saccharase cycle or excessive sweating over the forehead and also it. That usually indicates child is having severe breathlessness and also used to have, and also increases sympathetic activity that indicates congestive heart failure in infants and young children. So if it is there, you have to ask that one. And now I will summarize and tell the provisional diagnosis for you to catch in the history. So this child, actually 2 years child with the history of fever, cough, and tachypnea, breathlessness is there, so suggestive of some lower respiratory tract. But history of presenting illness, that is some right cough is there, and very severe enough to interfere with the feeding. And also this form of breathlessness was observed by mother, grandmother, and past history of palpitation that indicates some congenital heart problem is also there. And otherwise, child no perinatal illness. Developmental gross milestones delayed means there is something since birth but won't affect in the activity. That's child is only gross motor means that's tone or something related to activity only. Otherwise, while motor, social languages are normal means brain is normal. There is not any defect with the brain. So anthropometric ways, there is failure to gain weight and height also. Height or length is there. So that's the anthropometric impression. And if you vital data, you can observe there is a tachycardia and also tachypnea. Okay. With fever. Fever is also there. So general examination, there is no cyanosis or anemia, but dysmorphic features are there, suggestive of some genetic syndrome most probably. With this history, the general examination findings, we may think child is maybe having some congenital genetic syndrome. So only if there is Down syndrome, we should not use this growth chart. This growth chart is for normal children. So we have to use the special charts for Down syndrome children. So on examination of systemic examination, this suggests of rise of JVP and left ventricular hypertrophy, precordial bulge is also there. So some congenital heart problem. And the tachypnea, tachycardia. So what could be your professional diagnosis needs? The case of most probably Down syndrome, genetic syndrome, most probably Down syndrome with dysmorphic features, suggest of upward slanting and clinodactyly. Other features not mentioned because we have to answer that simian trees and saddle gap, increased saddle gap in the lower limb, that is increased gap between the great toe and second toe, and all other features suggestive of most probably Down syndrome with congenital heart disease, cyanotic heart disease, because no cyanosis was observed. So congenital cyanotic heart disease, most probably left to right shunt with PDA, or VSD. So not mentioned systolic and diastolic murmur, systolic and diastolic component is also there, means then we can consider as continuous murmur and PDA. Only systolic murmur here, it is pan-systolic murmur, most probably VSD also, VSD with congestive heart failure features like tachypnea is there, palpitations are there, tender hepatomegaly, always suggestive of congestive heart failure in pediatric age group. If there is tachypnea, tachycardia, palpitations and tender hepatomegaly and the hepatojugular reflex present, this indicates congestive heart failure. So congenital cyanotic heart disease with congestive heart failure with associated lower respiratory tract infection, most probably bronchopneumonia, with failure to gain weight, failure to thrive. Child is having failure to thrive because he is having congenital heart problem, because of that is and also genetic problem. So that's why he is having failure to thrive. Okay, that's what we have to put the different provisional diagnosis. Provisional diagnosis should include all first, because he is having some genetic problem. You have to mention genetic problem first, then congenital cyanotic heart disease, most probably left to right shunt with VSD. For a VSD, we can't confirm it, but clinical features are suggestive of with congestive heart failure and lower respiratory tract infection with failure to thrive. Okay, is it clear? Any doubts? Pawan? Am I clear?
Yeah.
Is it clear? Huh? Any doubts you can ask me. I think 8 more minutes are there. So what is NADA's criteria? Which roll number 30? What is NADA's criteria? So whenever you get a case congenital heart disease, they will ask about the NADA's criteria. If this acquired heart disease, they will ask about rheumatic fever. What criteria we will use?
Jones criteria, ma'am.
Jones criteria. So congenital heart disease, they will ask NADA's criteria. What is NADA's criteria? Roll number 30 option. 31. 32.
Ma'am.
30 Anusha.
Ma'am, 30 present, ma'am.
Anusha, tell about the NADA's criteria. Never heard?
Yes, ma'am.
What is NADA's criteria? There will be major and minor. What is the major?
Ma'am, in major,
major
systolic heart murmur of grade more than or equal to 3, ma'am.
Okay.
Systolic heart murmur.
Grade 3 or more.
Diastolic murmur.
Any grade of diastolic murmur?
Cyanosis.
Cyanosis. One
and
more
heart failure, ma'am.
So heart failure. So if any actually systolic murmur of grade 3 or above, if it is pan-systolic murmur, any grade is a major. Actually, it is given in detailed description. But systolic murmur of grade 3 or above, cyanosis, diastolic murmur of any grade, and congestive heart failure. If it is there, you have to major criteria. Consider as major criteria. Minor criteria.
Systolic heart murmur of grade less than grade 3, ma'am.
Okay.
Abnormal S2.
Okay. Abnormal second sound. ECG changes? ECG changes are there or not?
Abnormal ECG, ma'am.
Abnormal ECG?
Abnormal chest X-ray.
Okay. So all of you read about the NADAS criteria. So when will you suspect congenital heart disease?
One major or two minor, ma'am.
So whenever these are there, we have to suspect congenital heart disease. We should carefully examine and then we have to confirm it by taking ECG, chest X-ray, and finally echocardiogram. Okay. So what are the complications of PSD? Complications of PSD. Roll number 33. Roll number 33.
Ma'am, 31 present, ma'am.
31. Reshma. Okay.
Present,
What are the
ma'am.
complications of ventricular septal defect?
Infective endocarditis, ma'am. Infective endocarditis, ma'am.
Okay. That's all.
Pulmonary stenosis, ma'am. Pulmonic stenosis, ma'am.
It's not a complication. It may be associated problem. Pulmonary stenosis is not a problem. Pulmonary hypertension. We can get pulmonary arterial hypertension and reversal of shunt. That's called as
Eisenmenger syndrome.
Eisenmenger complex. The Eisenmenger syndrome. That's in the late complication. Okay, early complications are they're more prone for infective endocarditis, they're more prone for congestive heart failure, they're more prone for repeated chest infections, lower respiratory infections, and growth failure. They may develop growth retardation. So those things you have to mention. It's very common VSD. You may get as a theory question or you may get as a long answer. Okay. So
Okay,
here, Pawan, can you discuss the hemodynamics in VSD? I think for first internal also you got the question. Pawan, ventricular septal defect hemodynamics. Which ventricle will be hypertrophied in ventricular septal defect? Pawan, which ventricle will be affected in ventricular septal defect? Right or left ventricle? Hypertrophy.
Left.
Be clear.
Left ventricle, ma'am.
Left ventricle, why? It's left to right shunt. Now, why left ventricle will be hypertrophy? Explain. Your answer is correct. Explain. Because VSD is an asymptotic heart disease, left to right shunt. Blood is going from left ventricle to the right ventricle, but still left ventricle will be hypertrophied, not the right ventricle. Why?
Ma'am, because the blood from the right
Blood.
ventricle goes to the lungs, and again the return to the right, left heart is more, ma'am.
Okay. So it's during systole, it's happening. So whatever blood going to the right ventricle will be pumped out to the pulmonary arteries. It won't stay in the right ventricle because it's a shunt is at the in the systolic phase. So this whatever amount of blood received by the right ventricle will be pumped out to the pulmonary arteries. These pulmonary arteries supply the lungs, and from the lungs to the pulmonary veins to the left atrium and left ventricle. That's why left ventricle will receive more blood in the next diastolic period. So left ventricle is hypertrophied, not the right ventricle. But once it is in chronic, then gradually pulmonary arterial pressure increases, then it will goes back and reflects in the right side. Then this in Menges right ventricular pressures also will increase. Then it will become right to left shunt. That is called as Menges syndrome complex. Okay? Is it clear? Any doubts? Any doubts? You can ask me because time is over. Any doubts? Pavan or any others? Divya, Chahat? Any doubts are there? Sweta? Anybody?
No, ma'am.
No doubts. Is it clear? If the case comes as cyanotic congenital heart disease, can you present in your clinics? Then I will leave if no doubts are there. Okay?
Ma'am,
Pavan.
Ventral septal defects లో cyanotic conditions, cyanotic conditions వస్తాయి అప్పుడు.
Ventricular septal defect. Pavan.
అంటే ventricular
Be loud and clear. I'm not able to hear you properly. There is some disturbance. Ventricular septal defect.
ఉన్నప్పుడు సైనోటిక్ డిసీజెస్ ఏమంటే సైనోటిక్ డిసీజెస్ ఏమంటే చెప్తారు.
So ventricular septal defect without any other malformations, only pure ventricular septal defect. It may be mild. It's depending on the size of the defect. It may be mild, moderate, and large VSDs. So in case of mild and moderate VSD, they won't manifest in the initial years. Only whenever there is associated infection, whenever there is associated anemia, the HB is less than 7 grams, like that, then only, or high grade fevers, then only they will manifest with congestive heart failure. But in large VSDs, they can manifest around 6 to 8 weeks of life. That is around 1.5 to 2 months when right-sided presence falls less than the left-sided presence. But if it is sometimes may be associated with VSD, may be associated with PS, that is pulmonary stenosis. It's like cyanotic car diseases. Okay. In case of tetralogy of Fallot also, it's mainly because manifestations are due to cyanosis and the spotting episodes mainly due to the pulmonary stenosis or pulmonary inflammatory stenosis. At the wall, there will be stenosis. So that problem they will present with cyanosis, not with congestive heart failure. Okay, and that's what you want. Pavan, what is your doubt? I not got it clearly. Just tell me clearly. With cyanosis or without cyanosis, you asked me?
Yes, ma'am.
Okay. Okay, anybody, any doubts? Any doubts? Then I will close the meeting. Okay? Okay, bye.
Thank you, ma'am.
Pavan. Okay, now we can end this meeting, no? No doubts means we can end.
Okay.